Good afternoon, everyone. Thank you very much for joining us here on this Tuesday afternoon. We will be going over the final rule that was released last week and the 2022 final rule finally saying MIPS ROI despite a harder program. With me today is going to be our CEO, Lauren Patrick, and I am going to be your host, Michael Lewis.
Good afternoon, everybody. I'm glad you could join us.
So a couple of housekeeping notes. There are handouts on the bottom right-hand corner of your screen. Those handouts include the slide presentation. Feel free to print that out or to save that to your computer, as well as there is some information, kind of like a short glimpse of what 2022 MIPS reporting looks like. And you also have the opportunity to ask us questions. There's a lot of information to go over in this presentation, so questions may be limited, but Lauren or myself will get back to you shortly after the webinar with any of the information needed for this. So what are we going to discuss today? Today we will review a number of things. One, the final rule and its highlights, how these changes will impact you, and what are you going to do now? What can you do today to make sure that you are prepared for MIPS in 2022? So there were some CMS objectives for 2022 reporting: delay and changes to reduce the burden on providers digging out of COVID-19. I think this is the second year in a row that we've seen this as part of their objectives in the final rule. They lessened some of the changes, pushed back things that we will discuss a little bit later in this presentation to give you a better chance of survival in the MIPS program during COVID-19. Keep the momentum of the quality payment program moving forward. While they have stalled some things, they also have planned out further and further down the line. There are definitely parts of the final rule that show MIPS and APP reporting and so forth all the way out past the 2025 program year. So this is the furthest we've seen them go out, but they are really pushing on making sure that we're doing this moving forward. And then the goal is to drive the providers towards these other programs, the MVPs and the APM models that are out there currently. Some of the overarching themes that were available: reducing administrative burden. They know a lot of this quality data takes time to do with, and they talk about it during the final rule, how long it takes to report this information and so forth. So they are cognizant of that and tried to make changes to reduce the administrative burden, simplifying reporting options, getting rid of the web interface in the future, for instance, and making all reporters report the MIPS categories and the MIPS quality measures is something that they're going for, and eliminating or changing measures that aren't garnering the desired outcome. There was a lot of measures that have been changed or eliminated this year, especially on the quality side, that had not had the impact that CMS wanted to have, so they are moving on in a different direction. Some of the major changes, the inclusion of the new eligible clinician types, and I'm going over these. This is just an overview. We'll get deeper into each one of these categories as we move along. Changes to performance thresholds, updating the complex patient bonus. There's an addition of a scoring policies for new class 4 measures, and the removal of some of the bonus points, including end-to-end high priority. There are a number of PI measure changes that are there. New cost measures are included, the re-inclusion of the web interface and extending the phase-in approach for the APM performance pathway, as well as further delaying the MVP category. So what didn't change? These things haven't changed in a while at this point. Eligibility still has $90,000 plus dollars in Medicare Part B spending. Charges, 200 plus Medicare Part B patients and 200 plus covered professional services. Eligible provider types, they didn't eliminate any. They did add a couple though. And quality data completeness is staying at 70% this year. So I'm going to throw this over to Lauren to discuss what the MIPS reporting frameworks look like.
Sure, thanks, Mike. So in the past, before 2021, basically MIPS was MIPS. And when we talk about MIPS in the old-fashioned or traditional way, that's what you see here in the traditional MIPS top set of reporting options. In 2021, CMS added the APM performance pathway, and in 2023, they're going to add the MVP. So this is all considered part of MIPS by regulation. However, they really are breaking apart all of the various options. What you'll see going forward is CMS is really trying to eliminate the reliance on traditional MIPS and move all providers into either APP or MVP reporting. So you'll see as we go forward, much more emphasis on those programs and a waning emphasis on traditional MIPS. You can still report, and you will probably be able to continue to report in traditional MIPS for a long time. We were at a conference a few weeks ago, and somebody asked the CMS representative about traditional MIPS, and they think it's going to probably stick around until 2030. I know that they sort of have a goal that in 2025, most people will either be in the APP or MVP. Having said that, within APP and MVP, you still have the concepts of a group, an individual, an APM entity. Virtual groups really have not taken off, but in 2022, 2023, what you'll see is the introduction of subgroups. And if you sign up for our webinar in a couple weeks, we will definitely talk more about MVPs and subgroups and how that's going to come into existence.
Great, thank you, Lauren. So they did finalize the changes for traditional MIPS for these, for your reporting categories and the percentages. As you can see, the one change is that in 2021, your quality score was 40% and cost is 20. However, in 2022, by law, they needed to change that so that both quality and costs were equal weighting at 30 points, 30% of your overall score. The areas for you to be able to get out of for exemptions and so forth remain the same, where for the most part, if you are reporting, if you are not reporting PI or costs, they will be moved into the quality category for you in 2022. So for those provider types and or small practices that take exemptions, everything will be moving back into quality just like it has been in the past. So the minimum threshold to avoid the penalty is increasing from 60 points to 75. The final rule raised the minimum performance threshold. And what that's really going to do is it's going to impact the reimbursement as well as those that are penalized. And we'll be able to show you a couple of those in a little bit.
So the reason that was changed to 75 is there was a mandate in the regs that said that by 2022, CMS had to be using either the median or at least the median or the mean for the payment threshold. And so CMS went back and they looked at the performance thresholds for the last few years, and that's how the 75 was arrived at. So it wasn't just let's go up 15 points. It was really based on calculations, based on looking at what the median and mean were in the prior years. The interesting thing is, as Mike goes forward, what you'll see is it's going to be a lot harder to achieve that median in the future. Some people have called it score inflation in the past because you could get a lot of extra bonus points, and or there were a lot of floors that automatically gave you some points in different categories. So while 75 points was the average in the past, it's going to be harder. I would bet that less than half of the providers in the future will achieve that 75 points.
Sure. So how does that impact you? So just taking a look at this slide over here or this graphic over here, achieving MIPS incentives will continue to become more difficult, right? So those providers that are penalized are going to be penalized higher at a higher rate because the threshold moving up to 75 increases those who are scoring really low into the 30s and 40s are going to get crushed by penalties. However, what that's going to do, since this program is a program that the people who get penalized pay the people that get incentivized, you're going to see some very high increased funds for those who are performing well. So those top performers, those in the exceptional performance and above, are going to be have a much higher incentive payment that's going to be paid out to them. There is no easy way out for MIPS. If you have talked to and been a part of my webinars in the past, we talk about what are the easy ways to avoid the penalty. There is no such thing in 2021 for the most part, but for 2022 for sure. Getting the 75 points is going to take full participation in all categories that you are included in. And then we also said that more providers, what Lauren was saying earlier, are going to be penalized this year. And that will be something that is uncommon to a lot of MIPS participants, as they've done a bare minimum to avoid penalty in the past. They will be receiving penalties moving forward. So taking a look at this screen, what you see here on the left-hand side graphic is a representation from the final rule showing what the expectation for MIPS reimbursement will be. If you can see, anything less than 20 points will get you a -9 rate. And then once you hit 20, from 20 to 75, you'll be in the negative as it climbs up through those numbers. And then once you hit the 75 points, you'll see that's where it crosses the 0 vertical horizontal line, the 0 horizontal line. And at that point, it'll increase the slightly increase in your rate as the percentage goes up. But then once you hit 89 points, you'll see a drastic increase, and that's where the exceptional performance bonus, that $500 million, will come into play. This is the last year. 2022 will be the last year for that extra $500 million. So with that said, they are saying that the potential could be as high as 14% for your top performers. However, from anybody that has been involved in MIPS for a long time, from our understanding here at HealthMonix, we also know that 14% seems a bit outrageous, and we're not sure we're going to exactly get there. I know that we've been disappointed in the last few years with the increase. However, we believe here at HealthMonix that the 2022 performance year is going to give the largest incentive that they've had in the prior years. Anything to add to that, Lauren?
Well, no, I think we've all been disappointed in the past in that, the first couple years, because the average performance was 75 points, and yet the threshold was 15 or 30. The bonuses were minimal, and then we thought, well, the bonuses would become larger in 20 and 20 or in 1919 or 2019 and 2020. However, what we've seen is, because of COVID, then nobody was getting penalized. So the bonuses, I have air quotes going on, were not, they were nothing to write home about. We believe, that again, precluding that COVID, becomes an epidemic like it's been in the past. We believe that, with the higher threshold, and also with the removal of all of the EUC ability in 2022, that we'll see a lot more people on the wrong side of this, and hence there will be significant bonuses. Of course, that could all change. If the pandemic turns around and begins to flare up again, or if CMS decides again to extend the EUC for various reasons more universally, we could see the same thing happen again. We don't believe that that's going to happen, but we don't know. Yeah.
And there were a couple questions that came on that, and I think I'm going to hit them up right now. The first one is what will the bonuses be? Question about the last couple of years of bonuses scoring in the upper 90s and getting such a low percentage, and that CMS continues to cut their Medicare currently. Well, as Lauren was stating, the big thing is that there wasn't money to pay into the pot because nobody was penalized. So the only money available for the previous years was really the $500 million split between everybody that did above the threshold. So the program is a zero sum, so the losers pay the winners, and they have that $500 million on top to help incentivize those exceptional performance people. So since there wasn't anybody paying into the penalty, nobody that scored below 85 last year got anything. And those that did score in the 90s, the highest I think we saw is right around 2%. So that anticipation was much, much higher for the 2020 performance period as well as the 2019 performance period. However, if they do get rid of that EUC, as Lauren was stating, we do expect these numbers to go up much higher. Another person asked, where did CMS say it could be 14%? So in the final rule, as you can see here on this chart, you can see in the top spot around 14% with a perfect score of 100 is in the final rule. And they're stating here basically that if 50% of the people fall below the penalty line and 50% of the people are above, and compared on previous scores from previous years, the top earners will get 14%. As we've stated a couple times, we don't necessarily believe it's going to be that high for your top performers, but there is an expectation that it could skyrocket compared to previous years. So quality measure benchmarks, I'm going to throw this right back over to Lauren to discuss the quality benchmarks and what the meaning of the class 1 through 4 stages are.
Right. So looking at this, this is a chart again from the final rule. And if you look at classes 1, 2, and 3, those are measures that have existed for more than 2 years. Certainly, if you submit a measure and you achieve some sort of performance and you've submitted more than 20 eligible instances, you'll get scored against the benchmarks. What CMS had proposed to do for 22 was to remove that 3-point floor and take it down to 1, but they decided with everything else that they're already changing, e.g. the bonuses that Mike will talk about in a moment, and some other things, that they wanted to leave it at 3 for 22. However, they did state that in the future, they plan to get rid of that 3-point floor for measures that have existing benchmarks. So there's no change, but be prepared for it in coming years. And then Mike, if you want to go to the next slide. So then there's this class 4 that is new this year. And what class 4 is it's your newer measures. It's your measures that were put in place either for the current year or the prior year. And what's happened in the past is eligible clinicians are hesitant to report these measures because they don't have benchmarks. And so it's kind of like a self-perpetuating problem that people don't report it because it doesn't have benchmarks. And so it doesn't get a benchmark because it doesn't have enough clinicians reporting it. So what they've done in order to encourage clinicians to report these, and in particular, mostly we're talking about the QCDR measures here, the specialty measures. What they've said is if you report a measure that is new this year, you will get at least 7 points for that measure. If they can put benchmarks in place, in other words, if they have enough providers submitting enough eligible instances, then you could get more than that 7 points. And hopefully that will happen because we see this as a nice opportunity for those of you that are in specialties where there are new measures to go ahead and get started on those measures and be assured of at least that base if you report at least 20 eligible instances. And then they're doing the same thing for measures that are 2 years old, where the base will be 5 points. And so if you report a measure, in this case, that was initially in the program for 2021, you will receive at least 5 points for that measure. So we see, again, this encouraging clinicians to utilize the newer measures so that they can get a benchmark, and then those measures will become more highly used in the future because there's the ability to score points, which just hasn't happened in the past. We've had measures that have been in place for many, many years that have never received benchmarks because nobody reports it for that reason. So if you're, look for measures that are brand new or that were new in 21, see if you can report those, and you could come out ahead.
Great, thanks, Lauren.
Sure.
So the quality component scoring policies for 2022. This is the drum roll of the sad news for practices this year. Removal of the 1-point bonus for high priority measures, removal of the 2-point bonus for the outcome measures, remove the end-to-end reporting bonus. Some of that, on top of that, where the harm is for that this year is that reporting extra outcome or high priority measures, which is something that I've preached over the years here, doesn't help you moving forward. You won't get the extra bonus points for reporting more than 6 measures. So 6 measures is all you really need to report your top 6 measures. Why is CMS doing this? They said that the bonus points were temporary. They were put in place to allow people to ramp up into these programs to gain their quality scores, and it simplifies the scoring for them so that could be understood quicker by more users and so forth. CMS is keeping the improvement bonus scoring to be eligible. The MIPS eligible clinician needs to earn a quality performance category score of less than or equal to 30% in the previous year for the 2022 performance period. Basically, what that's meaning is that if you did not participate or you scored lower than 30 in the quality category, in the MIPS quality category, I'm sorry, in the MIPS category, you can get an incentive for improving on that score. Some of the things when it comes to the measures, they have upped the measures. There are a number with substantive changes. We'll have a list later in number order of what some of those measures are. They are removing 13 measures this year, adding 4 measures to the quality category. Their goal was to get to exactly 200 measures in the total finalized for the year, and they did that. As you can see, the numbers don't add up in the right-hand column. That's because many of these measures, for instance, could be a CQM and a claims reported measure, or a CQM and an ECQM. So there's a lot of doubling down on those measures there, as well as the web interface measures are almost all duplicates to the other measures that are in the system. So there was a lot of change this year. I think the best thing to do, it's early enough in November now for next year to take a look at the measures you're planning on reporting, see where they stand when it comes to are they going to be around in 2022, to make sure you're prepared to have 6 solid measures moving forward. Here are the list. I'm not going to go through them, but as you can see, there are a number of them are pretty popular. I see a diabetes measure on there. I see smoking. I see high blood pressure. There are a number of these measures here that have substantive changes, and I use that in quotes as well, because substantive changes to CMS is very, very small. Changes could be considered substantive. That could be a change in the coding for the measure. It could be change in a denominator eligible visit, things like that. So take a look at these measures though, because there may be something that impacts you and your specialty. Measures that they are adding this year, they're going to be adding 4 new measures, or 5 actually. So they have the list here on the right hand side with lots of big medical words for you, but they are there. And then there are some other quality changes, including a new certified nurse midwife specialty measure set, as well as they are extending the availability of the CMS web interface measures as a collection type for the 2022 MIPS performance period and sunsetting the CMS web interface measures starting with 2025. So if you are MIPS reporting, you can report through the web interface one more year in 2022, and then that will go away. But for ACOs, it'll be available all the way till 2024, where they'll be moved to the ECQM, CQM reporting options. These are the measures that are being removed. They were said that they were going to remove 19 and only removed 13, but as you can see, there are some pretty popular measures in here. One that got Lauren and I laughing earlier was that they're getting rid of measure number 154, which is the falls risk assessment, but they are not getting rid of 155, which is the falls plan of care, and you have to do them together. So I kind of think that they're getting rid of both of them without telling us they are. But these are the other ones that they are getting rid of for the 2022 year. So when choosing measures, we came up with some helpful hints here of what needs to do. Select measures that fit into your specialty and workflow. As I've had the opportunity to work in a lot of specialty groups, one of the biggest complaints is that why were they reporting on smoking or pneumonia when they're a specialty provider? There are more measures now. There's availability for you really to pick up some measures that are closer to your specialty. Not saying for all specialties, but for a good chunk of them. Determining measures that have smaller denominators. The smaller the denominator, the heavier the impact you can have on your score by seeing one or two more patients or doing correcting your mistakes or correcting your misses and gaps in care. Identify measures that are not topped out. There are a lot of measures that recently are topped out. So you have the ability here to really take a look at those measures and make sure that you are only choosing measures that, one, I mean, you're going to have to pick some topped out measures for the most part, but understanding that getting 7 points or getting not being able to get 10 points unless you're a perfect score is a possibility on a lot of measures in 2022. Examine measures that you can report as ECQMs, as the benchmarks may provide higher performance points. I think when I looked across the board, most of the measures that had both CQM and ECQMs give you the opportunity to score more points with the ECQMs. Finding new measures that you can report as they will yield at least the 5 to 7 points. Lauren talked about that a couple slides ago. They are really pushing for us to be able to get people to utilize new measures so that they can continue to grow the quality program instead of asking the same questions year after year after year. Finalizing some of the changes for the MIPS Pro, for the MIPS promoting interoperability. There you go, I stuck a little sales pitch in there for the MIPS Pro. Applying the automatic reweighting for clinical social workers and small practices for promoting interoperability. That is new for this year, that the small practices are now eliminated. Revised reporting requirement for public health and clinical data exchange. Objective to support public health agencies during future health threats and long-term COVID-19 recovery process. I think, there was a lot of lessons learned during this pandemic around the world, obviously, but in the healthcare industry, most importantly. And one of them is that they need to prepare these programs to be able to include that. Add a fourth exclusion for the electronic case reporting measure that's going to be available in 2020 performance period only. Require MIPS eligible clinicians to attest to conducting an annual assessment of high priority guide of the safety assurance factors for EHR resilience guidelines. Safer guides, I could have used that. Beginning with the year 2022 performance period. And modifying the prevention of information blocking attestation statements to distinguish this from separate information blocking policies. Improvement activities. This is the most change I've seen in improvement activities in a long time, actually. They are modifying 15 activities as well as adding activities that have to go around health equity. So some of the changes are to the example, enhance engagement in Medicaid and other underserved populations, as well as eligible clinician leadership in clinical trials. They are removing 6 activities, and the 7 that they are now including for this year moving forward include 3 improvement activities pertaining to health equity. Examples of that are create and implement an anti-racism plan, as well as implement food insecurity and nutrition risk identification and treatment protocols. During a previous webinar that Lauren and I did on return from our ACO convention that we went to, CMS spent a lot of time discussing health equity, and that definitely is a word that is peaking across the entire spectrum of all of their programs moving forward. And the idea is that that even things like their ACOs that they have been putting on don't take a great example of the population of the United States, as it leaves out a lot of minorities and lower income families compared to the wealthier areas that are taken in on a lot of these quality programs. When it comes to the cost category, they're finalizing the changes for cost. It was by law that it needed to be done by this year, that cost and quality are the same. What's been very interesting and I think pretty scary for a lot of people is that cost was last really seen in 2018. 2019, it was automatically reweighted. 2020 was automatically reweighted. 21, you don't have, much information to go off of right now. And you're jumping basically from 10% to 30% of your overall score. Understanding what is involved in your cost score, what you can do about it is vital. It is November now, so this is a good time to get a jump on understanding what you need to do for cost and how you can do it. So a couple of changes to the cost category. And I think what's interesting here is it's going to add a number of specialties on that are going to have to pay attention to the cost score. So there's new episode cost measures. There's one around melanoma, colon and rectal resection, sepsis. There's an asthma one and diabetes one. That's going to open up a lot of providers to need to worry about costs, as I said, and move more towards where they're looking at with the MVPs, where each of the different specialties to have an MVP will need to have a cost measure moving forward. So what are chronic condition episode-based measures? They're expanding on the previously established framework for episode-based measures to address unique factors inherent to the continuous nature of chronic disease care management. Here's some more on the chronic condition episode attribution. So a new attribution framework for identifying and confirming a clinician-patient relationship for the proposed chronic condition measures, as well as how they're going to attribute those measures to clinician groups and what the trigger events are. Our total attribution window can span multiple years. That's very important and something that a lot of providers have a hard time because these MIPS programs have been year on year. But these cost windows can go over and span multiple years. Individual clinician performance is based on all the episodes attributed to the individual clinician, and the group's performance is based upon episodes attributed to the clinician group. So no matter how it slices your cost score, if you're part of a group, you will be impacted by the total group cost score. If a single episode is attributed to multiple clinicians in a single clinician group, the episode only counts once. So that was an important update for this year on cost. So I did want to introduce our MIPS cost analytic platform. I've mentioned it a couple times in the past, but in seeing how the cost category is now 30% of your overall score, this is the most important year moving forward with cost. So MIPS Cost Analytics is the first and only technology platform that's providing current year payment data for all Medicare patients. It gives you the access into your MIPS score throughout the year for costs, provides actionable insight into each of the measures, identifies your anticipated attributed patients and episodes, gives you the ability to share individual patients' HEC scores, and allows you to easily identify those patients and providers that have the largest impact on your costs. You could break that data down in a number of different ways so that you can get the greatest impact on bringing that score. Because as we showed before, with the penalty avoidance rate being at 75 points, if you score poorly in cost and score perfectly in everything else, you're going to be mighty close to that penalty range, because that being at 30 points, if you scored a 0 in cost, you will be penalized in the MIPS program because you'll score below the score. I'm going to throw this over to Lauren so she could talk a little bit about the new MIPS value pathway framework.
Thanks, Mike. So MVPs were originally proposed for last year, and when we all looked at it, we went, wow, because it was a big shift. CMS definitely wants MVPs to be different than MIPS in that they really want to focus on single specialties. There's been a lot of pushback from a lot of providers and provider groups to say they think that they should be multi-specialty, but CMS seems committed to making these MVPs be single specialty, and for multi-specialty groups, they're going to have to report several different MVPs. And so it's going to be challenging. It's going to be different. In some ways, if you're already a single specialty group, we almost liken it to the old PQRS. Oh geez, what were those called? They had groups of measures. So in some ways, if you're a single specialty group, you'll have a group of measures for quality. You will have at least one cost measure. The foundation will be PI. A couple of the pop health measures, which are the measures that the larger groups are already getting assessed with for quality, and then patient-reported outcomes. CMS is promising additional performance feedback. We are obviously anxious to see what that is. There is a lot of subtle complication in MVPs, and so we're planning to do a webinar in a couple weeks to really talk through all of the nuances. Certainly not settled yet. We've been part of several discussions with CMS about how do you define a subgroup, who's eligible for reporting an MVP, who has to report an MVP, how will benchmarks be set? Will an MVP have different benchmarks for measures than the overall traditional MIPS? And a lot of those, I think, have not been settled yet. But certainly we do know some basic foundational operational components of the MVPs. And so we want to get started educating folks and preparing for at least the 7 that were put forth in the final rule this year. The 7 that were put forth in the final rule are intended to be implemented for 2023. And I'll pause there in terms of MVPs.
Cool. Thank you, Lauren. So taking steps to maximize your return on investment, everything is just becoming more important. These aren't very new steps that I've gone over, and if you've listened to my final and proposed rule webinars that I've done, maximizing what you get out of your quality measures, making sure you're choosing the right measures. It's not easy. There are many specialties, and I have a number of questions that came across the board already today. There are a number of questions about their specialty and choosing measures. It is not easy. There are not a ton of measures that are out there. The old measures that you can do well on, taking a look at the newer measures is important. Understanding what the upcoming benchmarks and so forth that are not out yet will give you the opportunity really to understand where you're going. And I think, to me, one of the most important things is having an internal meeting with your staff to discuss the importance of MIPS in 2022. Use this deck. You'll have opportunity to have it, as well as the video that you can share with everybody on your team. It is a good start for the 2022 year, getting them all on the same page. I've witnessed it myself, is the most important thing to do well, because you could work as hard as you want when it comes to MIPS, but if there is someone within your organization that's in charge of a certain measure, a certain recall system, or calling patients for bringing them back in, whatever it may be, and they're not doing their job, it could cost you a lot of money. And getting the right tools in place. Have your EHR down, your submission platform, your billing company, consultants, telehealth program. So I just saw a question come up right here. How does the telehealth impact MIPS? There has been a number of changes during the COVID that have impacted MIPS, none more so than the telehealth measures. So there are two things. There are measures now that include telehealth billing visits as part of the measure. So take a look at those measures and make sure that you can either do that measure for patients that over telehealth, or that they could be exempt from those measures. So that's also a possibility. The other thing for the telehealth measures is there are a number of measures that are completely exempt from telehealth. Most of your outcome-based measures and so forth, you can't do through telehealth. So they changed some of the rules, they changed some of the billing around it, but telehealth does have a big impact on MIPS, and moving forward, it will have a larger one as well. So reporting methods, why a registry? Maximizing your return on investments, more measures. Registry like MIPS Pro, we have over 200 measures, gives you better options for reporting your specialty, allows you to pick these measures in which you score the best. Utilizing experts, work with MIPS experts, so consultants or your team here at MIPS at HealthMonix, help you navigate through all these changes. Use all of your data. That's something that we talk about with a lot of our customers, utilizing all of your data. If you have data in billing, if you have data on paper, if you have data in other areas within your EHR that aren't normally used for MIPS but can get you the MIPS answers, if you have lab results coming in with A1Cs and so forth, have the ability in that to report to report and help gain the best possible score you can. Tracking your data all year long has the ability for you to maximize your performance improvement. Being able to see your misses and your gaps in care in January and February can really help when you're finishing up the year and looking at results. Reporting on ECQMs and CQMs to maximize your score. If you're able to get that clinical quality data directly from your EHR into a registry like ours, we can report those ECQMs for you. And dig into your data and attack those gaps. Really look into it. We have a lot of tools within our program that allow you to separate patients by provider type, by their PCP, by diagnosis and so forth, that allows you really to dig into each one of these patients and understand what's being missed for each one of them. So getting started early in the year, start tracking each category in January, complete your 90 days for PI and IA right away, so you don't have to worry about it for the rest of the year. Utilize a program like MIPS Pro that can provide you those quality benchmarks all year long. Focus on performing your improvement by attacking those gaps and cares. We have utilizing your EHR, ensure the appropriate data is being collected. That's really important. Providers determine if someone is not carrying their weight. Patients, are there a certain patient type that you're not getting the answers that you need from, whether it is a group that's 65 and over, whether it's your diabetics, things like that. Take a look at that and see the measures and determine what measures may have been overlooked. There are opportunities working within a registry or even your EHR where you can take a look at every measure, and maybe there's a measure that you're 21 over 21 halfway through the year, or 10 over 10 halfway through the year, with a not topped out measure that you can really score well on, and something that you didn't think you could even report on. Track more than 6. We recommend that you choose between 8 and 10 measures and watch their performance, and start eliminating the measures throughout the year. As I said, in 2022, you will only be able to report on 6 measures. Well, you can report on more, but you'll only be able to receive points on 6 measures with no bonus points available. So start eliminating your measures throughout the year so that you can optimize your time while working on this. MIPS Pro offers live dashboards, drill down capabilities that help identify gaps in care, performance improvement, score optimization. Our easy to navigate dashboard is designed strategically for administrators to understand, track, and then drive that performance improvement, leading to higher scores, higher reimbursements, and improved patient outcomes. Really being able to dig into each one of these patients and look into each one of these measures to understand where your gaps are and how you get better and how you have higher reimbursements. And ultimately, and if you talk to Lauren for any length of time, you'll understand that our belief here is that we are doing all of this to improve patient outcomes and patient care. And we really believe in that, and we really believe that data is one way that you can do that. So how's MIPS Pro able to help you? Our best-in-class US-based support team and integration teams are here to reduce your burden of quality reporting, allowing you to do what you do best, and that's providing the highest quality healthcare to your patients. Please don't forget our next webinar, our next November webinar is going to be on the future of MVPs. Lauren gave you a little teaser earlier, but we will be going all over that on November 30th. So while you're stuffed from your Thanksgiving meal and leftovers, come and sit down with us and we'll teach you a little bit about the future of MVPs. You can feel free to contact with any questions. contact@healthmonix.com comes directly to me. And I will get answers for you for anything that you need. If you're looking for more data and more information, you can visit mipspro.com. So we have about 13 minutes or so of our time here, and I want to make sure that I'm able to get to some of the questions. But Lauren, did you have anything to add while I'm looking through the questions real quick?
I do. I have 3 points to make, Mike, so thank you. The first is, I want to clarify that for web interface, somebody asked this question. 2022 is the last year, so they've extended it, so 2022 is the last year you can use the web interface, and what we mean by that is you can report in 23 for 22. So I hope that clears up any confusion. The second point is, I don't think we covered this well, the complex patient bonus for 22 will be more difficult. In years past, everyone got some sort of, nearly everyone got some sort of complex patient bonus because it was scored on basically a scale of from the bottom to the top. What they've done this year for 22 is they've changed the calculation. So only those that have more than the median score for complex patients in terms of HCC, or more than the median number of patients that are dual eligible, will receive any complex patient bonus. So I wanted to call that out. If you want more details on how that's being calculated, because it is pretty complicated, let us know and we can help you understand that. But again, I just wanted to point out that a lot of folks, I think they said 36% of providers will not receive any complex patient bonus in 2022. And the third thing I wanted to talk about, which somebody mentioned, is for the cost component, we will be holding another webinar for cost to explain it. We've been working for the last couple years on actually gathering providers' cost data and being able to help you understand how your cost score is being calculated. So we want to do a webinar kind of explaining a lot of the basics and then talk about how we can help you in more detail if that's something that you'd like to focus on in 2022. So I'll pause there and let Mike go back to questions that you had.
Okay, sure. So give me 1 second as we're doing it. What's the difference between ECQMs and CQMs? You want to take that one, Lauren?
So in ECQM, oh geez, what's the difference? An ECQM is intended to be reported totally electronically with no human intervention. If you have an ECQM, there is a different set of benchmarks, but basically a CQM is something that you report through a registry, and you can have manual intervention involved in reporting that measure.
Great. How do you locate class 4 measures?
Oh, that's a really good question. We know which class 4 measures we are reporting through our QCDRs and our registry, but maybe that's something, Mike, we should develop a list of. We could do that. That's a great question.
Someone also asked, where are the telehealth measures? Where can we find those? Those are on our webpage. What telehealth measures are available? I'm not sure that we've updated for 2021 yet, as the benchmarks haven't come out yet, but we will have 22, sorry, but we do have the 2021 telehealth measures.
Right, there are no benchmarks, there are no specs yet for the 2022 measures. Those typically come out to us in December. I think CMS's commitment is that it comes out in December, so honestly, sometimes we get them on December 31st, but as soon as we have them and can disseminate them, they will be available on our website.
Great. Someone asked about the automatic reweighting for small practices for PI. That was not automatic before. You had to actually go in and take a exemption, but the new current rule is that they are going to automatically reweight PI for all small practices. Now, I will tell you, you can report the PI and get those points for PI, and if you perform better in PI than you do in quality, that will be worth your while to do that moving forward. Let's see what else we have. You know, a lot of people are asking Lauren in here, what do you do for these specialties that don't have new measures and don't have the ability to add different measures? Their doctors don't do immunizations, they don't do things like that. What are your suggestions for really trying to find the best measures? Do you have any advice for them?
Well, I know that, you know, we can take data in and we can look through the data and determine which measures could be reported with your data. And then from there, you can discern if you're going to have enough eligible instances and if your performance can be enhanced. Other than that, talk to your specialty, I guess. I mean, we've worked with quite a few specialties to develop measures, and I think that's actually what CMS is trying to do, is to encourage folks to have more measures that are specialty related.
Great. Terrific. That's really it for the questions that are not specific to an individual person that I'd like to share at this point. So if you do have more questions, please reach out to myself or my team and we'll be happy to answer. There is a lot going on in MIPS right now. Please pay attention to our webinars, as well as we do a blog series. And if you are a customer of ours, we do have sent out a lot of a monthly newsletter that you'll have as well. So if you can, and if you want, please reach out to me here at the number and email that you see below. Thank you, Lauren, very much for your time. And we look forward to talking to everybody soon.
Thanks, Mike, and thanks everybody for attending.
Bye-bye.
Bye-bye.